So our last speaker of the breakout session is two pharmacists that have worked with us on a project to look at substituting dry powder inhalers for metered dose inhalers. So I'd like to welcome Kathleen Silveira and Claudia Pham to the stage.
Hello, everyone. Thank you, Dr. Sims, for the introduction. So yes, my name is Kathleen. I'm a pharmacist at St. Luke's, and this is Claudia. She is our PGY1 community resident, and this is largely one of the projects that she's been working on, and I'm going to do a little introduction, and then I'll pass it over to her. So our project is on the environmental impact and other benefits of sustainable inhaler prescribing and substituting. Before we get into it, I just want to say that we don't have any disclosures or sponsorship. Did just want to give a shout out to one of the other pharmacists who is also an advisor on the project, Shannon, in the back, and then Dr. Sims was also part of this project, so thank you for your knowledge. All right, so just give an overview. St. Luke's offers a lot of services throughout the state of Idaho, but some that I really want to focus on that do make this project possible is one of them is Meds to Beds, which is my primary role, where we go to patients' bedsides, deliver medications at discharge. And in that, a lot of patients who are here for asthma and COPD exacerbations do have the opportunity to either start inhalers or optimize their inhalers. And that is an opportunity that I get to change people to dry powdered inhalers very commonly. Another thing is the collaboration with Medication Access and 340B. So everybody knows that medications are very expensive, especially inhalers. Some of them are $700 just for a 30-day supply, and insurance doesn't always have the best coverage. So through this program with 340B, we are able to help patients get the inhalers that they need at a fraction of a cost or even sometimes zero. So just to give a background, in the state of Idaho, pharmacists are permitted by law to substitute a drug with another inhaler in the same therapeutic class without any sort of approval from any physician or advanced practice provider. We do send a notification to alert them of this change, but it is a really nice part of our law. In 2024, we did create this substitution protocol originally, and that was developed through our outpatient pharmacies. So the protocol covers inhalers, proton pump inhibitors, and insulin. And the goal of doing this was to prevent any delays in care when we do get prescriptions sent to us that either aren't covered or don't work for the patient, to address any sort of insurance challenges, like I said, and then any sort of back order. Drugs are on back order constantly, and this is a really great way to be able to navigate that. And lastly, to help any patients with administration difficulties. Some inhalers are definitely easier to use than others, so it's really nice to just be able to change that based on taking the patient into a full picture. All right, now I'm gonna pass it over to Claudia, and she's gonna tell you about her project.
Hi everyone, my name is Claudia. Thank you, Kathleen, for the lovely introduction. This is my longitudinal project. So I updated the list of inhaler on the 2024 protocol. Just a side note that we started out this protocol in January 2024. So I picked up this project in the fall of 2024. There was a few inhalers that were discontinued on the market, but it still show on the protocol, so I wanted to remove those just to make it easier for pharmacists to navigate to the substitution chart. The second part of this project was to promote the dry powder inhaler usage when appropriate. There are several studies that were done in Europe and Canada show that dry powder inhaler associated with lower carbon footprint without compromising disease management in patients with COPD or asthma. Secondly, the metered dose inhaler use hydrofluorocarbon propellant. These propellant are very good at trapping heat in the atmosphere. Over time, it will create global warming. Based on a 2022 Center for Medicare and Medicaid Services metered dose inhaler, MDI accounted for 49 million claims, which resulted in over 1 million metric ton of carbon dioxide versus dry powder inhalers, DPI. They took only like 1/3 of the claims, so about 17 million, but they only produce a smaller fraction of carbon dioxide to the environment, so about 0.018 million metric ton. So what is the therapeutic substitution protocol? So on this protocol, we clearly say out the criteria, documentation, and communication to the providers and patient. And on top of that, I show a list of substitution for the inhaler that I'm gonna show with you guys in a bit. So first of all, criteria. We want the substituted medication to be a cheaper alternative in the same medication class. And the original prescription has a lack of insurance coverage or is not included in the patient insurance plan. If there's a drug shortage or if there's a lack of inventory in the pharmacy, we can provide the inhaler in a timely manner for the patient. And lastly, ability to administer the inhaler, because inhalers are not one size fit all. Sometimes it fit for like certain group of patients, but it might not fit for other patients. Documentation, so we want our pharmacists to document the original prescription, what medication that the patient was originally prescribed with, therapeutic substitution, what medication that we're changing to, and the reason why we're making that change for the patient, whether it's an insurance coverage or it's the patient ability to use inhaler. Lastly, provider notification. So after we're making this therapeutic change, we want to let the provider know that, okay, we're making this change for your patient. And we have a template sheet that pharmacists can use to fax to the provider. Communication to providers, as I mentioned previously, and to the patient. We want to get the patient consent and counsel patient on the substituted medications. Here are a few examples of the substituted medication. So I divided the inhaler into three different categories. First one is single agent, second is dual combination, and third we have triple therapy. And in each of the category, I further divided into different medication class. For example, for single agent, we have inhaled corticosteroid, long-acting beta agonist, or short-acting beta agonist, etc. On each of these tables, I reorganize it so it's based on formulation. Dry powder inhaler, DPIs in green, metered dose inhaler in red, and soft mist inhaler is in blue. Okay, we have a pop quiz. A Ventolin inhaler produces about 28.2 kilograms of carbon dioxide, which is equivalent to the carbon footprint of a gas-powered car driving for how many miles? A, 60, B, 85, C, 95, D, 110. Anyone want to take a guess? Okay, I get the D. C. Anyone else? I heard someone say B. Yes, B is the correct answer. 85 miles, 137 kilometers. Isn't that so crazy? Like these like little inhaler can produce like that much of carbon footprint to the environment. Thank you for the participation. Okay, so the objectives of my project were to study the environmental benefit of utilizing the inhaler therapeutic substitution protocol. And secondly, we want to evaluate the financial impact when we utilize this protocol. Last thing, we want to learn more about all the benefit of the protocol that we have at St. Luke and encourage the use of dry powder inhaler when appropriate to do so. So the timeline of this project, so we started out in January 2024. That's when we implemented the substitution protocol by the previous resident. Then we wrapped up the result by April 2025 because I need the result and data to present at another conference, which I presented last week. And I sent out like educational material to our pharmacists in February of this year, so about 3 months ago. We have a total of 11 interventions, and we compare the original prescription to the therapeutic substitution. The primary outcome that we looked at was the carbon dioxide emission, kilogram of carbon dioxide. And the secondary outcomes that we looked at is the cost to the patient and medication cost to the system. So with the primary outcome from these 11 interventions, with the original prescription, these 11 inhalers can produce up to 215 kilogram of carbon dioxide to the environment. And after we make in therapeutic substitution, we found that they produce about 79 kilogram of carbon dioxide. So in total, we prevented about 136 kilogram of carbon dioxide released to the environment. So what does it mean, 136 kilogram of carbon dioxide? So 135.9 kilogram, to be exact, is equivalent to the environmental impact of a gas-powered car driving for about 409 miles. Another piece of information I want to give you is in the US, there are approximately 70 million inhalers prescribed every year. So yeah, I want you to keep this number in mind because it's a massive carbon dioxide footprint that we release to environment from these inhaler prescription. So beyond the environmental benefit, what are the benefits that dry powder inhaler DPI offer? So they're easier to use. The patient doesn't need to have that hand-breath coordination like MDI, because like elderly patients sometimes have the sterility issues, so it may be easier for them to use dry powder inhalers. They're less frequent dosing, typically dosed once a day. If we look at real Ellipta to like Symbicort or Dulera, it will help improve patient adherence. And there are a lot of variety options available on the market. We have Discus, Ellipta, HandiHaler, and FlexHaler. One thing that I want to point out is that dry powder inhalers might not be the best option for patients with limited lung capacity. And we have a device called Inject Dial. This is a handheld device that helps clinicians to train patients to use more or less inspiratory flow rate to achieve the optimal flow rate for whether it's DPI or MDI. For the secondary outcomes, we looked at cost to the patient. Same thing from these 11 interventions. We found that it could cost patient up to $3,000. This could be insurance issues. And after we make the therapeutic substitution, these 11 patients only pay $311. So we save about $2,745 for the patient. Medication cost to the system, the last outcome that we looked at, so this one we looked at the acquisition cost. So the original prescription would have cost about $3,000 as compared to therapeutic substitution, cost a little bit less, about $2,700. And we save about $300 for the system. One thing that I want to make note is that not all substitution result in the lower medication cost to the system. That's why you see a smaller decrease after the therapeutic substitution. Okay, I'm gonna turn it back to Kathleen.
All right. So, pharmacists being able to implement this protocol helps to decrease the carbon footprint. It saves money for not just the patient, but also for the system in a lot of cases. And it also can prevent delays in care and promote adherence to medication, like Claudia was saying. Symbicort, which is 2 puffs twice a day, versus Brio, which is 1 puff a day, is going to have a lot greater chance of patient buy-in when it comes to daily use of inhalers. So pharmacists really do play an instrumental role with this, and since we're at the heart of the pharmacy, it's super easy for us to just change these to make it better for the patient and the environment without having to contact the provider in most circumstances in order to do it. So how can physicians and advanced practice providers be involved? So Prescribing inhalers is very difficult. There's so many things to look at, the guidelines, their ability to use the inhaler, looking at the lung capacity, their dexterity, or even their age. And then, of course, their insurance coverage and how much the cost will be out of pocket to the patient. And lastly, their preference. So there's a lot to look at, and sometimes it's very difficult to decide which is going to be best when you're in that moment in clinic or in the emergency room. So I think just focusing on dry powdered inhalers, and when you're prescribing, at least at St. Luke's, we do have this protocol that we can assist and help, because there's not going to be one easy thing that fits for every patient. And then looking at the future directions of this project going forward, as Claudia closes her resident year, we are going to continue tracking therapeutic substitution interventions post-education. Education didn't go out till February, so there's lots to still go over with that, and making sure that our pharmacists remember to track that. Next, expanding education outside of just the pharmacy, so hopefully reaching pulmonology, the emergency room, internal medicine, and any other clinics or spaces that may be interested. And then lastly, we are also looking to implement a pharmacist prescribing protocol for reliever inhalers, so that we at the pharmacy level, without seeing the provider, we can prescribe those reliever inhalers, which can be really handy when patients are on maintenance inhalers but don't have a reliever. And that wraps up our project, or our presentation. What questions do you have for us, if any?
Kathleen, just one quick question. If you had to recommend one dry powder inhaler, inhaled corticosteroid, long-acting beta agonist combo for us to prescribe as a default when we don't know anything, what would it be?
Brio would be my first choice. Yeah, it's once a day. It's getting better coverage as time is going on, and yeah, it's a dry powder inhaler. So anytime I can do that for an ICS LABA, I'm for it. Yeah, good question.
I have a quick general question. I know in Epic, like when we order things, there'll be like a money sign that tells you how expensive it is. I was wondering if it would be possible to integrate like a sustainability leaf, because I think sometimes with all the different names of inhalers, and I know I'm a resident, so I'm like figuring everything out, if I just saw something that indicated that it was better, and I think maybe across a system in general, like if there could be some way to indicate, so you can just quickly be like, oh, that's a good one, and click. But I don't know how that would work on a system level, or if like, or if pharmacy, like, I always appreciate when you guys say like, have you thought of doing this? And I'm like, oh, yes, please. But I don't know how that would work, or if that would be possible.
That could definitely be something that we look into. I like the idea of, drawing a little bit more direction to it, because I think it can be an overwhelming choice. So that would be something that we could talk about with maybe IHT and see if that could get added. Yeah, for sure. What's your thing? Oh yeah, and we did bring the in-check dial with us in case anybody wanted to see it after. It's mostly used by respiratory therapy, but they gave me one so that I could use it to educate and just show that not every inhaler is an option for every patient. Okay, thank you.